We'd like to invite now Dr. Sanjay Chaudhary, who is going to talk about his early experience with EVO, VIVA, ADOF, IOL. I think that is a change which is going to happen in the practice of phakic IOLs for a presbyopic correction. And let's hear from Sanjay what is his experience in Indian eyes with this.
Thank you, Dr. Tityal.
In the meantime, I think we have to go down so that they can prepare the stage.
So I'm very excited about this new introduction in the family of ICLs. So from a normal monofocal, we are crossing the threshold and we are going to monofocal to EDOF ICLs, and it is called the EVO, VIVA, EDOF ICLs. So this is a very interesting phase, a very good option for people who are entering the presbyopic age and are myopic. Right now, in all these people, we used to correct them either for distance, and overnight they needed glasses for reading, or we thought we will do a monovision, one eye for distance and one eye for near, which not everybody was very comfortable with the idea. We didn't want to do an RLE. It's too early to do an RLE for them. So we had actually no options. And now this is opening up a whole new segment for those people for which we didn't have any solution in the near past. So this is an elderly person over the age of 45 who can watch the TV and also see his mobile, despite the fact that he was myopic for, say, last 30 years, and now he has this advantage. Now this is the basic concept of the design. So it's a smooth radial variation in power across the optic from the central to the periphery that reshapes the wavefront. So it is a refractive optic. It is not a diffractive optic. So there are no rings, no diffractive rings. These days we have developed an antipathy towards the rings. We said anything which rings is probably in the psyche of a present ophthalmologist not the way to go. So this is without rings. It is a refractive optics, and the periphery of the lens provides more power than the center. That's easy to understand. For example, if the periphery is -7, the center could be -5.5. So that is how you would get that myopic gradient, right? Central region creates a slightly myopic region to provide near vision. So to understand these principles, just I'll make you understand by these 2-3 slides. Understand this slide. A bundle of ray of lights coming in, which is the yellow. This is the refractive surface, which is the lens. In this case, let us say it is a EVA Vivo lens. It forms an envelope of rays of light which are focused on the retina. So this envelope of waves of light is now referred to a term called caustic. And the focus is shown here as a small dot. Now the significance is, this is what is the caustic. That means this envelope of rays of light. And the smaller the dot, the better the focus on the retina, right? The light is focused on the small circular area onto the retina. The smaller the circle, the better the focus. This is the basic principle, naturally. Now, look at this. A football coming from distance to near. In a normal person, as the football comes from distance to near, the focus changes and the vision gets blurred in a presbyopic person. Here you see, again I'll just show you. Don't look at the football now. Look at this caustic. This wavefront is hardly changing. It's still a sharp point focus. That is the property of the EDOF lens. Now watch a comparison. Above is an EDOF lens, below is a monofocal lens. We showed you that in an EDOF lens, the caustic shows that there is hardly any increase in the focus spot size. And look at this. In a monofocal lens, the caustic showed that the focus increased from a small point to such a wide area. That means that is what is causing blurring. Let me show you again and focus on the lower diagram, that is the monofocus lens. The football is approaching in a monofocal person. See the way the wavefront is changing. Now this is his problem. That is why he cannot see something for near. And the EVO, VIVA, EDOF, ICL is now with us in India. We have had experiences with 3 patients, 6 eyes, and it's my privilege to give you my early experiences, share my early experiences with you on this lens. So this is the video. I hope we have the sound.
First time the ICL
Sound?
with the EDOF.
Sound. We don't have the sound. Where is the sound? Huh? Jack, एक तो लगा हुआ है.
First time the
Yeah.
ICL has come with the EDOF mode, which is called extended depth of focus. That means it can give you a vision for distance and also correct your vision for near. So this patient tomorrow should be seeing for distance clearly, and she should also be able to see her mobile or read the newspaper or a book.
VDZP, VDCTZP. If we decide to donate our eyes after death, then it is absolutely useful to someone. My
She is
name is
reading
Rigzin
N6.
Hamu Bhutia, and I'm from Sikkim, and I'm teacher by profession. I'm 45 years old, and my right eye is -4 and the left is -4.5, and I've been wearing glasses for the past 21 years.
So now, what we are going to do with this new generation of ICL, so this is the new generation ICL, which is called EVO VIVA ICL from Star Surgical. And this generation of ICL is going to correct the vision for distance and also correct her vision for near. So which is the first of its kind. It's been launched internationally. It is FDA approved, and this patient is going to get the benefit of this lens. Spectacle power in the right eye is -4, this. And the lens calculation is that the size of the lens is 12.6 and the power of the lens is -5. And this is the lens. This is from Star Surgical, and the power is -5, and this comes with an additional focus for reading. The lens looks exactly the same as a normal monofocal Star ICL. I'm placing it in the injector cartridge. So I'm loading the lens. So the lens is loaded. So this is in position. So we're doing the process under hydro insertion. So this is the lens opening up inside the eye. Whatever little strands of the visco are there, we have removed those strands of visco.
Sorry, I wanted to show you the hole. So the only differentiating point is this partial hole identifies the VIVA lens. See that here? That's the only giveaway that this lens is a VIVA EDOF lens. It's a partial thickness hole. So don't be worried that what is this additional spot lying there.
remove those strands of visco. We are tucking in the first haptic, the second haptic, the third haptic, and the fourth haptic. So the lens is in position, the surgery is over. I just have to now hydrate the entry points. Now what is different? We would normally expect that in the optical area there would be rings for near vision. This lens shows no rings for near vision. It just looks like a normal monofocal lens. So 5 minutes both eyes, like I promised, no pain. Great. Just a little feeling of touch of pressure. Both the surgeries have gone very well. Absolutely perfect. We'll take you out now. You could rest here for an hour or so, and then we'll discharge you. So tomorrow when we meet again, we'll check out whether this lens delivers.
Can you remove your glasses now? We'll take your vision on. Okay?
Sure.
Can you see what is written there?
V,
Now?
FK,
Now?
TDZP,
Now?
VDCTZP,
Now?
HPKSTZC,
Now?
ZPEHSRD.
The vision distance vision is perfectly fine. It's 6 by 6. Now we'll take your readings. Are you able to read this line?
Okay. If we decide to donate our eyes after death, then it is absolutely useful to someone.
Okay.
That is
Okay.
N6.
Okay, ma'am, you are able to read the most detailed lines also properly now.
And this morning was much better, and now right now it's completely normal. Like it's everything fine. Like I can see everything so clearly, and this is a wonderful experience. Like such a relief, actually.
So that was our first patient. And we did a bilateral implant, and this was her first post-op day experience. Encouraged, we did a couple of more. So this was the first case data. -4 in the right eye, -4.5 in the left eye with an add of +1. Target was 5 minus in the right eye, 6 in the left eye. And the post-operative data, day 1 was 6.6 right, 6.9 left. Of course, we expect it to improve over a period of time. That was just the first post-op day. Vision intermediate at 55 was N6, N6, and near at 30 was N8, N8. Then we have another case. This had a number of -3.5 with an add of 1.5. -5 was the target. And this we had a follow-up of day 1 and day 15. So it was 6.6 distance, intermediate, N8 first post-op day, but after 15 days it was N6, and near at 30 was N8, N8. That means she was still requiring an add of 0.75, probably because she had a number of 1.5, so the lens in her case covered about 0.75. And the third case, this is the data, -6.75 and 6.5 with an add of 0.75. This was the power of the lens. And, sorry, this is it, 6 by 6, 6 by 6, N6, 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 distance and intermediate and near. So the 3 cases, the results were very encouraging. So we had an uncorrected distance vision of 6.6 in all, uncorrected intermediate at 55 centimeters N6 for all, uncorrected near N6 in one case where we had to use an add of 0.75, otherwise it was N6 without any add. A longer follow-up and more cases are needed to understand this lens better. Thank you so much.
So thank you, Dr. Sanjay Chaudhary, for that wonderful talk. I have also a limited experience of maybe one patient, a bilateral implant, and the patient is doing very well, 45-year-old gentleman, -5 with 0.075 add, 6.6 N6. So I think that partial thickness hole is just to, if I'm not wrong, to figure out that if the patient comes on post-op to any patient, any doctor, that we can know whether it's a VIVA or a EVO
Exactly,
ICL.
yeah.
Yeah, thank you. So any quick questions? So we are now stage.
Ye- Basically, you add a power of 1. If it is -5, it becomes -6 when you're correcting. I'm sorry, that was a wrong data entry.
So I think very nicely picked, but actually the ICL size goes one diopter up. So that's the ICL power that he was mentioning. So, but you correctly pointed out that's wrongly mentioned.
Yeah. Yeah, I
Yeah,
noticed that. That was a wrong data entry.
Yeah, so that was wrong data entry, I believe. Thank you.
Dr. Chaudhary, I mean, great, but as we all know, EDOF lenses are slightly deficient for real near vision. So do you think going forward, once we get enough experience with this, is doing a mini monovision, maybe in a non-dominant eye, giving a extra 0.5 or leaving behind -0.5 would be a good idea, so that bilaterally implanted, then patients would have better reading vision?
I think though that was the future, because it is still an EDOF. It is still correcting, say 1 or maximum 1.25. That time would tell us with our experience. Right now we are selecting only those people who are in their 45s, 50s, who still have an add of about +1. We are not going for the ones who have an add of 2.25. But yes, as we understand the lens better, micro monovision should be the way to go. I totally agree with you.
Trying to play with the limited amount of accommodation that the patient still has. So that's why the limited, between 45 to 50 years of age. But I think that's a great idea, to do a mix and match and try to undercorrect for distance, and then works very well. So I think that could be some future. So now we have.
One question to Ramamurthy, sir.
So by the time we take up the question, we can have the stage arranged for the laser show. So I'll request
Sir,
everybody to
in all
go down.
micromono vision patient, do you check stereopsis?
Well, we can do a contact lens trial. When we didn't have these EDOF lenses, when I had to implant these lenses, I used to have a difference of 1.5 diopters, full correction in one eye, and in the non-dominant eye, maybe make it less by about 1.5 diopters. So it used to work. I usually give a contact lens trial and see whether the patient is comfortable with that.
But I think you should go for stereopsis checkup also in these cases.
I know. I mean,
Yeah.
that would be ideal.
It will be a very good binocular
Yeah,
system then.
yeah.